Good afternoon, everyone. I want to thank you all for coming today to the meeting of Subcommittee 4 in the 3M Committee. The committee is Social Services, Mental Health, and Children's Affairs. We have one item on our agenda today, but we have quite a number of individuals who have requested to be heard. So we will be moving fairly expeditiously to value your time. Before we get started, I want to do a couple of housekeeping issues. I hope you all can hear me. It's difficult, I know, sometimes with the mask, but I want to make certain you can hear. We're going to ask those who are participating virtually to please mute your microphones unless you are speaking. And I do know that we have several people who've signed up to speak virtually. And when providing testimony, please make sure that your volume is up. And if you're using Microsoft Teams, please mute online streaming in the meeting when testifying. If not, we'll get a horrible echo. And for those meeting with us in person, we want to thank you for wearing your mask and for keeping them on during the hearing. Having said all that, we are ready to begin, and we will ask the staff to call the roll.
Ms. Brawley.
Present.
Mr. Hill. Absent. Mr. McCabe.
Here.
Ms. Murray.
Present.
Ms. Robinson is absent, and Mr. Howard.
Here.
We do have a quorum, so we will begin. I have the sponsor of the bill with us today, the primary sponsor. So Representative Collins, I'm going to allow you an opportunity to address your colleagues.
Thank you, Madam Chair, and thank you, Chairman and Subcommittee for hearing this bill. First, at the outset, I apologize. We're also in judiciary right now, so I'm going to be leaving. I wish I could stay here. But in short, this bill is to update our Nurse Practice Act, and from my perspective, to give more flexibility to especially our rural areas. The intent of the bill is not to mess with any current policy that some of our providers have in the upstate of South Carolina. I'm in Pickens County. We're primarily ANMED and Prisma. This bill is not intended to affect how they do their business with anesthesiologists, but the intent is to open up that practice, especially for rural areas. And also the flexibility. I believe you have a map of 42 states in South Carolina, 42 states in the nation do not require supervision of our anesthesiologists or anestheticists, and this would give that same flexibility to South Carolina that 42 other states do. But with that, I'll be happy to answer any questions, and I will be watching afterwards, but I appreciate your time.
Thank you, Representative Collins. Are there any questions from the committee for Representative Collins? Well, thank you, Mr. Collins, and we know that you are hard pressed for time to get to the next committee meeting, so thank you for being here to introduce the bill. I'm going to, for the record, just also read a brief summary of the bill so that those who may not be as familiar will have the information as well. This bill will eliminate the requirement for physician supervision or certified registered nurse anesthetists, CRNAs. The bill also changes the existing requirement for a CNRA to practice pursuant to approved written guidelines. Currently, the guidelines must be developed under the supervision of a physician, dentist, or medical staff within a facility where practice privileges have been granted. The bill will require the guidelines be developed with a physician, dentist, or the medical staff within a facility where practice privileges have been granted. The bill also repeals a provision of the Medical Practice Act that requires a physician or dentist responsible for the supervision of the CRNA to be identified on the anesthesia record before administration of the anesthesia. And that is just a quick wrap-up summary of the bill. We have a variety of individuals who have signed up to speak, and we want to hear from all of you. What I'd like to do is to start with those of you who are in the room, and we will be going in a particular order. So as I call you, if you could come to the center microphone, push the red button, and then we can begin. Yes, thank you for that reminder. Because of the volume of people who have signed up to speak, as well as those who are on the virtual to speak with us about this bill, we are limiting you to about 2 minutes, I think, so that everyone will have an opportunity to have their say on the bill. So I'd like to begin first by hearing from Dr. Marcia Izzard. I hope I'm pronouncing that correctly.
Speak, or do I need to keep it up while I speak?
We prefer you keep it on, but if it becomes difficult for us to hear you, we
I'm
might have
fine.
to.
Okay, thank you. Good afternoon, Madam Subcommittee Chairwoman, Mr. Chairman, and Subcommittee members. My name is Dr. Marcia Izzard, and I'm a certified registered nurse anesthetist. I have been practicing as a CRNA for the past 11 years. I have practiced in multiple environments, which include the anesthesia care team with an anesthesiologist and as the sole anesthesia provider. Currently, I am the chief CRNA of an anesthesia department here in South Carolina, where I practice in an anesthesia care team. Therefore, I'm not attacking the anesthesia care team model. However, the team effort is always there with every anesthetic I deliver, regardless of the model in which I'm practicing. When practicing without an anesthesiologist, if an emergency arises, I'm fully educated and trained to handle those emergencies. I'm the person not only handling the emergency, but I'm usually giving instructions to the other members of the patient care team as to what needs to be done next. This even occurs in the anesthesia care team model because regardless of practicing with an anesthesiologist or practicing with a surgeon, I'm the person that is with the patient for every second, every breath, every heartbeat, keeping the patient safe from the very beginning to the end. Let me be clear before continuing. CRNAs are not asking for independent practice. Removing the word supervision from the Nurse Practice Act does not remove the patient's physician involvement. There is not a lesser standard of anesthesia care when a CRNA is delivering anesthesia without an anesthesiologist. The standard of care is the same if a CRNA is practicing as the sole anesthesia provider or in an anesthesia care team model. Certified registered nurse anesthetists are master's and doctorate prepared advanced practice nurses. We have a minimum of 7 to 8.5 years of education and training specific to nursing and anesthesiology before we are ever licensed to practice. We have a license before we take care of the patient independently. We have an average of 3 years ICU experience taking care of the sickest patients in the hospital. We then attend a master's or doctoral degree nurse anesthesia program where we obtain an additional 9,369 clinical hours on average.
And I'm going to have to interrupt you at this point because you're a little bit over the 2-minute provision.
Okay.
But we thank you for your testimony. I want to ask the members of the House, are there any questions for Dr. Izzard? Representative McCabe.
Yes, sir.
Thank you for coming. How would eliminating the physician supervision requirement contribute to patient safety?
So there are no patient safety issues with CRNAs. If you review the evidence there, all the evidence says that there is no difference in outcomes, whether CRNAs administer anesthesia alone as a sole provider, or if they administer anesthesia in an anesthesia care team model. I can definitely tell you how it can increase access to care, and recently with COVID, how it would have improved things in my facility. If you would like that example. Would you like an example of that?
Well, I'm not sure I followed you on the part about how eliminating the supervision would contribute to patient safety.
Well, eliminating physician supervision doesn't have an effect on patient safety because CRNAs are already proven to be safe whether they're practicing as a sole provider or whether they're practicing in an anesthesia care team model.
Thank you. Next, I think we will hear, and thank you, Dr. Izzard. We appreciate that. Were there any other questions before moving on? Thank you, Dr. Izzard.
Okay.
And now we'll hear from Dr. Wendell James.
Good afternoon, Mr. Chairman, members of the committee. My name is Wendell James. I'm an anesthesiologist of 40 years. I am the former chairman of anesthesiology at President Greenville I practiced in the team model for my entire 40 years. And to answer your question about effect on safety, I go back to an analogy about airlines. Every airline has two pilots. In the right seat, you have a co-pilot. He's got 2,000 hours plus or minus experience. In the left seat, you have the pilot in command. He has 18 to 20,000 hours of experience. When I walked out of my training, I had about that much more training than a CRNA. It's about 2,000, 3,000 to about 15 to 18,000 before I touched the patient, independent. So taking physician supervision out of anesthesia and or the operating room, removing supervision from the conduct of anesthesia with CRNAs would be the equivalent of taking the pilot out of the left seat of an airplane. When you have a situation in a plane, like the landing on the Hudson, the co-pilot wasn't making the decisions. The pilot made the decisions. Because at that point, everything that was happening was off the page. And it had to be experience, 18, 20,000 hours or more of training, and being able to essentially do what needed to be done with decisions being made in seconds off of that experience to save all those people. The operating room is no different. When you take the physician out of this equation, which is exactly what they're asking you to do, that is the exact same thing as taking the pilots out of the cockpit. You have a co-pilot running the airline. And none of us, halfway to Dallas, with the left engine falling off the wing, are going to find that as palatable thought, nor is it the best care for the customers or the passengers. That is exactly the same thing as we're talking
Thank you,
about
Dr.
here.
James.
Thank you.
Were there any questions of Dr. James before? Yes, certainly, Representative McCabe.
Thank you. In reviewing this bill, one thing I'm struggling with and wanted to ask some people here today is, in the event a patient were to have a severe allergic reaction to the anesthesia or the code, who would be in charge of this bill if it were passed, the nurse or the doctor?
In the situation with the bill as it's presented,
Correct.
the CRNA would not be obligated to do whatever the doc said do. The physician is still the one that should be held responsible regardless of anything going on with that patient. But what this does is it disrupts the team. There is no clear person in charge anymore. That always has to be the physician. We're talking about physician supervision, not an anesthesiologist doing the case necessarily, but the surgeon, the proceduralist needs to be the one clearly in charge of that patient. And anything that person in charge, captain of the ship, whatever you want to call it, says goes. Captain of the airplane. So what you're talking about is basically disrupting the team concept and not allowing for a clear leader on the team. And regardless of what they say, that is what we're doing.
Thank you, Dr. James.
Does that answer your question? I'm sorry.
Mr. Hill, you have a question?
Yes, one question. Dr. James, appreciate you coming today. If I understood you correctly, you said you have 18 to 20,000 hours of training
Yes, sir.
at the end of the process as a anesthesiologist. Can you tell me and clarify for the committee, are you saying that you've had 18 to 20,000 hours on nothing but anesthesia training and practice?
On total training is about 18,000 hours.
Total training on anesthesia practice?
Most of us are working in training somewhere around 4,000 hours a year, plus or minus. And if you do a four-year residency, you're going to put in somewhere between 15 and 18,000 hours, depending on how you do
So
it.
as an anesthesiologist in training, going through your residency, all that, you're doing nothing but anesthesiology, hands-on practice during that whole entire time. Is that?
Pretty much, yes.
Okay.
Now, everybody has an off-service year. Everybody has 1 year or 12 months where they're off service, which means that what the physicians are doing is going and getting cardiology training, urology, nephrology, pulmonology. So what that gives us the ability and depth of experience to do is diagnose problems and manage them perioperatively and intraoperatively. You have the diagnostic training to make decisions at the time when it makes a difference.
So you're spending a lot of time training on issues that may intersect with anesthesia.
They all intersect.
But not all of that 18,000 hours would be on anesthesia in
Let's
and
say
of
that
itself.
12 to 15,000 would be just anesthesia, yes.
Okay, thank you.
So, but what all of the training does, anesthesia is one of the most cross-linked practices there is left from a specialty standpoint. Anesthesiology touches medicine, cardiology, radiology, surgery, orthopedics, all of it, pediatrics, because at some point, for some reason, all of those patients are going to need an anesthetic for a procedure. And so breadth and depth of the training that the anesthesiologists have to bring to bear has to be very, very extensive and broad.
Thank you, Dr. James. Our next speaker is Elizabeth Wilkes. Is Elizabeth Wilkes here?
Good afternoon, Madam Chairman, Madam Chairperson Brawley, and Mr. Chairman, fellow members of the House 3M Subcommittee. Thank you for allowing me the opportunity to speak with you today. My name is Elizabeth Wilkes, and I'm the President-elect of the South Carolina Association of Nurse Anesthetists. I have been practicing anesthesia for nearly 2 decades after graduating from the University of South Carolina School of Medicine in 2004 with my master in nurse anesthesia. I want to tell you my story and why the COVID-19 pandemic has shown us that artificial barriers to nurse anesthesia practice must come down, particularly physician supervision of certified registered nurse anesthetists. I provided anesthesia at the Aiken Surgery Center for 2 years without the presence of a physician anesthesiologist. I was with the patient in the preoperative area where I performed a pre-anesthesia assessment of their body systems and coexisting diseases, daily medications, and prior surgical history. I rendered the patient unconscious for their surgical procedure, established an airway such as inserting a breathing tube for the procedure. I provided relief of their pain with medications, often with nerve blocks. I monitored their vital signs and emerged them from anesthesia at the conclusion of the surgical procedure. In other words, I woke them up. I was available in the post-anesthesia care unit or the recovery room if the nursing staff were to need my services until they were discharged. As a CRNA-only facility, this surgery center had the most cost-efficient model for our patients. The barrier to practice here was that I had to be supervised by a physician. Not specifically a physician anesthesiologist, but simply any physician. In this case, the surgeon or the physician performing the procedure. These physicians did not necessarily have any emergency critical care or anesthesia training, which I do have. My chart had to be signed by this physician as well. Unfortunately, the largest obstetric and gynecology practice in Aiken was not comfortable serving as supervising physicians when we transitioned to a CRNA-only practice. As a result, surgical cases that would have been great candidates for our ambulatory surgery center are done at the hospital, which significantly increases cost to the patient. They also have increased wait times, both in getting their surgery scheduled and while they are at the hospital when they're having their procedure. Medicare Part A supervision requirements state that hospitals and ambulatory surgery centers require physician supervision. This is a payment construct, not a safety construct. However, the previous administration gave an executive order to the Centers of Medicare and Medicaid Services to waive supervision in March of 2020 at the onset of the pandemic. This order has continued under the current administration and was recently extended for an additional 90 days. This waiver will likely be extended through the end of 2021.
Ms. Wilkes?
Unfortunately, South Carolina...
I'm so sorry to interrupt you.
That's okay.
Because it seems as though you are quite on a roll, but I'm going to have to stop to allow our colleagues to ask questions, should they have any. Are there any questions for Dr. Wilkes? Well, thank you.
Thank you.
Victoria Pollard. Dr. Pollard.
Thank you for your time and for your service to South Carolina. I'm Victoria Pollard. I'm a pediatric anesthesiologist at Prisma Health Richland, which I've had the pleasure of working for the last 5 years. I grew up in Manning, South Carolina, and I'm proud to call South Carolina home along with all my family and a lot of my friends. I'm here to talk to you today about this bill because I want the best health care for our state and for all of my family living here. This bill, if passed, would allow a nurse anesthetist to practice without supervision, which in my book is very scary and detrimental to our health care. You also see that we have a letter from every South Carolina medical physician group, including the South Carolina Medical Association, that is against this bill. To start off with, I love my CRNAs I work with. I work in the team care model. We work well together. I enjoy going to work every day. I'm also involved in teaching the nurse anesthetist students, and I love doing that. They're a great group of people, and I want them to do the best they can be. The care team model is used throughout the United States. In my training, I've been to Tennessee, Georgia, Florida, Ohio, Kansas, Pennsylvania, and West Virginia. And it's all worked exactly the same with the physician supervision. I've been in every one of those, or operating rooms in every one of those states. I've also been on medical mission trips. And as a medical student, assisting surgeons that didn't have anesthesiologists in the room, and those surgeons weren't able to supervise the anesthesia providers. Unfortunately, I've seen stroke and death after those cases that we were trying to help those people directly related because of the anesthesia care that was lacking. The World Health Organization has issued a statement that wherever possible, an anesthesiologist should be involved in the care of a patient under anesthesia. There's nowhere in the state that I know of someone can't get anesthesia if they need it. If an anesthesiologist isn't there to supervise, then the surgeon or the dentist can supervise the nurse anesthetist. They're not going to get a procedure without someone doing it. Studies have shown a 15% increase in death rates when anesthesia nurses practice without supervision. They've also looked at these areas where they practice without supervision, and there's no increase in the number of procedures done, and there's no decrease in the miles that the patients have to travel to get their surgery. So in short, passing this is going to increase our patient risk, but not really give them any of the benefits that you're trying to give them.
Dr. Pollard, we have to stop you.
Yes, ma'am.
And see if there are questions from my colleagues on her presentation. Hearing none, thank you so much for coming.
Thank you very much.
Next, we have Dr. Candace Aguiar. I hope I'm pronouncing that correctly.
Close enough, it's
Close
Aguiar.
enough? Okay.
Good afternoon, Chairperson Brawley, committee members. I'm Dr. Candace Aguiar. To address Representative McCabe, there are no measurable differences in quality of care delivered by CRNAs versus any other anesthesia providers. Safe and effective anesthesia is tied to education, training, and certification, which CRNAs are required to be before they administer anesthesia independently. It's not true of our physician colleagues. So safe anesthesia is not tied to the title nurse or doctor. It's tied to education, training, and certification. In states that have opted out of supervision, there were no significant differences in patient deaths between the periods before and after opting out. The data simply does not support that patients are at increased risk when CRNAs work without physician supervision. Our malpractice premiums are the same, whether we work with a physician anesthesiologist, physician supervision, or independently. And in states that have opted out of supervision, our premiums have decreased on average by 25%. The South Carolina Institute of Medicine and Public Health has confirmed that physician supervision has consistently been shown to be unrelated to quality. Standards and regulations not related to quality can harm consumers by decreasing choice. 80% of our anesthesia providers in rural counties are CRNAs, and 50% of rural hospitals use a CRNA-only model for obstetric care. As has been mentioned, physicians and surgeons receive little to no education and training on anesthesia, making the requirement for them to supervise CRNAs appear to be risky and burdensome. I recently asked a spine surgeon I work with what was the first thing that came to mind if he was working in a facility where the surgeon functioned as the physician supervisor for the CRNA. And his response was, "We're going to get sued." This kind of erroneous belief is widespread and represents a major barrier to access when surgeons choose not to work in facilities or leave facilities that adopt a CRNA-only model. So the benefits of expanding choice are clear. Unencumbering practice can make services available where they once were not, or where surgeons are willing to work with CRNAs because that erroneous belief is removed by removing the words physician supervision from the law. I had a code in my room a couple weeks ago. I work in a care team model, however, I'm in the room all the time. The anesthesiologist may not even be on the same floor. So the patient's heart stopped. I looked over at the patient, checked the pulse. I informed the surgeon, who had scopes in his hand, we need to start chest compressions. Or I said, we have no pulse. And he said, well, what are we going to do? And I said, well, we're going to start chest compressions. I directed the person in the room to hit the code button. The staff came in. It was another CRNA who came in first. We also had called the anesthesiologist, as I'm required to do. And I performed chest compressions on the patient. Looked up, the patient had a organized rhythm, and we identified the rhythm correctly and checked the patient for a pulse. She had a pulse. He said, well, what do we do now? I said, well, you know, the anesthesiologist is here now, so where I work, they're the ones making the decision, but.
Dr. Aguilar, I'm so sorry.
Oh, that's okay.
But I have to interrupt. Are there questions from members of the committee? Yes.
Yeah.
In the scenario you described where a patient had the coded or heart stopped, whatever the appropriate terminology is, who is in charge of the emergency, the doctor or the CRNA?
Well, the doctor asked me what we were going to do. So in that instance, I would say I was in charge.
Okay.
Because surgeons are not required to have advanced cardiac life support training. We are required to have that as a course of our job. We have to be it's called ACLS, which teaches you how to identify heart rhythms, you know, above and beyond our original training, and what medications and treatments to administer to correct that. We're also required to have certification to do that in children. And for when people work around neonates a lot, there's also a neonatal version of that. But surgeons are not required to have ACLS training.
But as far as control of the emergency under current law, the doctor is supposed to supervise.
He's nominally supervising me, yes.
But he's supposed to he or she are supposed to supervise. But under
Yes.
this bill, there would be no supervising attorney. Supervising
So the
doctor.
supervising is not to increase the quality of care or the safety construct for the patient. That's a requirement for reimbursement for Medicare Part A for hospitals if they want to bill for supervision.
Okay. Are there any locations or settings in which the CRNAs are currently prohibited from providing anesthesia services?
No, currently we can provide anesthesia services in all settings for all patients for all types of surgeries. However, in the example that I gave, you might have noted that that supervision requirement can become burdensome, and physician groups have left, as Beth Wilkes pointed out, and surgeons believe they're liable for our actions. They are not liable for our actions unless they attempt to direct the anesthetic. That makes them liable because they have no training in which to do so.
Thank you very much. Are there any other questions, Mr. Hill?
Thank you, Ms. Aguilar, for being here today and taking our questions. I have a few things. One, you know, I've been intrigued to hear various folks that I've spoken with make statements about the safety of anesthesia, and some have, one doctor that I spoke with in my area recently said that anesthesia practice nowadays is extraordinarily safe. Has that been your experience as well, that anesthesiology practice, or the practice of anesthesia, rather, be precise with my terms here, is extraordinarily safe?
It has definitely come a long way. In the 1850s, when nurse anesthetists originally started doing anesthesia, we used a finger on the pulse and vigilance to observe the patient's skin color and whether they were breathing or not. So now we do have many scientific advancements in monitoring. The medications that we use are much more advanced, less flammable. So it has gotten safer. But yes, it does require a body of knowledge in order to do it. You do need to be trained in the administration of anesthesia from start to finish. And
is it been your experience that you are trained on that?
Yes, absolutely. I was in the military for 16 and a half years and practiced independently in that arena.
Okay, all right. Another thing that has been brought up to me by some of the physicians that are opposing this, and I want to see how you respond, would be that the VA has studied this from, I think, 2014 to 2017 and opted not to go with independent practice of CRNAs. Can you speak to that?
Sure. So in April 2020, the VA issued directives to allow nurse anesthetists to function according to the full scope of practice of their, the full scope of their education and training, rather than the state licensing in which they worked. I can't recall when the initial rule came out, and they had a huge political onslaught of letters from physicians. So we were cut out of the original ruling. Since they have a new director, which seems to be favorable to us, we had a new interim rule comment period, and we expect that ruling to go in our favor this time because the commentary was more favorable towards us, towards CRNA full practice authority than it was to limiting it.
So it sounds like the VA is having the same conversation that we're having here right now,
Yes.
or one that's very similar. One additional question, in comparing the effects of states that have passed similar legislation to what we're considering, first of all, would it be true to say that you, as a CRNA, the CRNAs that practice in the state would be required to carry their own liability insurance?
Yes, and we currently do. I mean,
Okay, and in states where similar legislation as this has been passed, what has been the effect on that liability insurance, the cost, the number of claims, the risks, and so forth? Has that gone up or down in those states that have passed legislation that removed the word supervision?
so in states where we have opted out of physician supervision, malpractice premiums have dropped on average by 25% and up to 33%. And we have.
So would it be true to say that the insurance companies then that are insuring your profession would, that their data and that their choices that they've made on premiums that they've, which, arguably are data driven since they use actuaries to decide their rates, would actually say to the concerns that removing supervision actually increases risk or increases or decreases patient safety, that those would be theoretical arguments that are not borne out in the data?
Oh, yeah, I don't think that, obviously, I mean, insurers are excellent at calculating risk, and they do that based on things that have happened, based on actual claims data. And so the fact that our premiums have gone down just bolsters what we already know, and it has been confirmed by many, many studies, that our anesthesia is equivalent.
And those premiums would ultimately at some point have to be passed along to the patient as part of the cost of care, would they not? Or would it at least contribute to that?
Well, yeah, it would certainly decrease my cost of care.
Sure. All right, thank you.
Thank you very much, Dr. Aguiar.
Thank you.
I think next we will have, hear from Dr. Tiffany Aiken.
Good afternoon, Madam Chairwoman. Thank you for this opportunity to speak before you. My name is Dr. Tiffany Aiken. I grew up here in Columbia, South Carolina, went to undergrad at Furman University in Greenville, and then University of South Carolina, Greenville for medical school. I'm here to speak on specifically the differences in training. That the most significant thing is the depth and the breadth of the training. From day one of medical school, we are prepared for independent practice. We work on our clinical decision-making skills and comprehensive care of the patient from day one. Ms. Dr. Dillard spoke about the number of hours that they are required to have for their training. We complete that in our 3 years of training specific to clinical anesthesia. We actually have double that amount when you include the last 2 years of medical school and our intern year, which is very important for us to learn the comprehensive care of these patients. A lot of these patients that are coming into surgery now are sicker. They have more and more medical problems. They're on more and more medications that can interact and interfere with the anesthesia medications that we're giving them. So it's not always a very straightforward case. Anesthesia is safe until it's not. And that's basically what I'm learning during my training here. If you want to speak numbers, so like I said, the total hours that we have training, not just the anesthesia-specific training, but in the total care of the patient, is on the order of 18 to 20,000 hours of clinical training, patient care, hands-on the patient, taking care of these patients. We take a total of 9 exams, certifying exams. That's 51 hours of sitting for a test. Not studying, sitting for those tests. And this, again, the tests, the things that we're being tested on are how to make independent clinical decisions. In the journal article put out by the American Association of Nurse Anesthetists in 2017 states that CRNAs spend an average of 3 years or 6,000 hours of critical care experience. But again, they're not making independent decisions during that time. In my residency, I've had to spend 2 months in the ICU. I'm the one that's making decisions, not the critical care nurses that are in there. So I think that's very important to point out and understand. And again, this is not negating their jobs, their skills, their experience, but just that there is a significant difference in the type and the length of training that we receive to begin with.
Thank you. Are there questions from members on the committee? Thank you very much.
Thank you.
Next, we will hear from Candace Carroll, Interim State Director, Americans for Prosperity.
Good afternoon, Madam Chair and members of the committee. My name is Candace Carroll, and I'm the Interim State Director with Americans for Prosperity, South Carolina. I'm here today to testify in support of House Bill 3682. Americans for Prosperity advocates for building a patient-centered healthcare system that lowers cost, increases choices, and improves access for millions of people seeking relief. Over the past several months, CRNAs have played an important role helping hospitals and other facilities combat COVID-19 thanks to emergency reforms implemented by South Carolina's governor. Last spring, as you know, Governor McMaster issued an executive order that suspended burdensome regulations that mandate CRNAs practice under a supervisory agreement with a physician. These temporary measures empowered CRNAs to utilize the full extent of their education and training to deliver life-saving care to patients with COVID-19. Unfortunately, this dramatic expansion of care is limited to the duration of the COVID-19 public health emergency declaration. Without additional action from lawmakers, patients will lose access to the essential services and support CRNAs provide when the emergency declaration ends. This bill before you would ensure that South Carolina's CRNAs can continue to deliver high-quality care long after this pandemic ends. This proposal would permanently authorize CRNAs to autonomously practice without working under a costly and burdensome supervisory agreement. Removing these barriers will empower these highly qualified providers to continue to support patients and facilities in underserved areas. Evidence from states that remove these costly supervision requirements show that CRNAs deliver more care in underserved communities after these reforms take effect. For example, one study from the University of Washington found that CRNAs are more likely to practice in rural areas after states allow them to independently practice. This committee can ensure more families receive the high quality and affordable health care they need by empowering CRNAs with full practice authority, and I urge you to vote yes in this committee to strengthen healthcare access, lower costs, and to end South Carolina's COVID-19 pandemic. I thank you for the opportunity to address this critical issue and look forward to working with all of you to craft real reforms that expand access to affordable and high-quality health care for all South Carolinians. And I'm happy to answer any questions.
Thank you, Ms. Carroll. Are there questions from the committee? Thank you so much for your participation.
Thank you.
And next we'll hear from Dr. Robert Ridgway.
Thank you, Madam Chair, and thank you, Mr. Hill, Representative Murray, Representative McCabe, and thank you for allowing me to be on this side of the mic. I'm a physician, for those who don't know me. I'm a physician. Practiced in South Carolina for almost 30 years now, in rural South Carolina, by the way. Prior to that, I was a registered nurse, so I've been trained in both modalities of nursing and medical school. I don't put people to sleep, except when I talk to them, and apparently Mr. Howard knew that, so he left the room. What I want to say today has already been said, basically, a lot of it. I would like to say that it was brought up about the airline pilot comparison. Yes, and in January of 2009, if you guys remember, Captain Sully Sullenberger put that plane down in the Hudson River. He experienced an emergency during the flight. It's been explained earlier about we experience emergencies during anesthesia from time to time. Thank goodness it's rare. I think it's rare, though, not in addition to the new training and the new tools and everything else we have, that we have more sets of eyes walking around that plane, kicking the tires, making sure it's in shape to fly in the first place. With two sets of eyes looking at a patient, especially from a physician's standpoint, having a deeper, he changed his mind, huh? Having a deeper understanding of pathophysiology of disease processes, sometimes that patient may be canceled for surgery for some other reason that they probably shouldn't have had surgery. Two eyes are always better than one. As for the process of access to care, you still have to have surgeons and everybody else. Unlike the expansion of the Nurse Practitioner Act that we did a couple of years ago. I assume my time's up because your light's on.
Yes, it is, Dr. Ridgway.
Yes,
Your
ma'am.
time
Thank you.
is up. Are there questions for Dr. Ridgway? Dr. Ridgway, I have a question, and that is, in the event that this were to become law in South Carolina, is there anything in the language that would preclude an anesthesiologist or a doctor from being in the room and continuing to at least be present in the event of an emergency?
I don't think it would preclude it. Having a deeper understanding of pathophysiology of disease processes, sometimes that patient may be canceled for surgery. Now that I listen to myself, I know why I put people to sleep. No, I don't think that would preclude it. However, like I said, it's more important to have the patient properly evaluated. And I'm not saying that CRNAs can't properly evaluate somebody. I'm saying that two sets of eyes are a whole lot better than one, especially when you understand disease processes in South Carolina, like hypertension, diabetes, lupus, underlying disease processes that are affecting most of our citizens. We don't have a big healthy population, as you may know, and that's one of the risks for surgery, some of those underlying disease processes. Renal failure is another one. Anyhow.
But just to be clear, though, the passage of this bill does not prevent other physicians from being in the room or being a part of the process. Is that correct? This simply just says there is no mandate for the supervision component.
You're right. It's just like flying that plane. It won't prevent you from putting two pilots in the cockpit, but it will allow one pilot in the cockpit having to manipulate all those instruments in case of an emergency.
All right, thank you, Dr. Ridgway. Are there any other questions for Dr. Ridgway? Thank you very much. Good to see you.
Thank you.
Next, we have two people who have signed up to speak in the room. No? Okay. Then we will move on to those folks who are waiting so patiently online to participate. I think our first person is Dr. Bruce Snyder from the South Carolina Medical Association. And Dr. Snyder, I just remind you that If you are participating through Microsoft Teams, you can now, he should unmute himself at this point. You can unmute your microphone. And Dr. Snyder, are you there?
I am. Thank you, Madam Chairperson. I would like to approach this from someone who does not compete or employ anyone in the anesthesia field. Have been a practicing vascular surgeon for 33 years in South Carolina. I've had a number of different roles, which include being president of the South Carolina Medical Association in the past. I am currently one of the 5 geographical delegates for the American Medical Association from South Carolina. I have previously chaired the Alliance for Healthier South Carolina. And my thoughts on this are very clear. As a non-anesthesia person, I have had complicated patients who have been extremely sick, who have had wonderful anesthesia by teams. I have never, since I left the Army, functioned in a situation where the CRNA was solely responsible for the care of that patient. I've had a number of episodes in vascular surgery where it has been necessary for me to actually ask one of my friends and colleagues who is a person to have the anesthesiologist come to the room, or to have other personnel call the anesthesiologist into the room to offer support. The training, both in duration and extent, is significantly different in those fields. The South Carolina Medical Association, your local American College of Surgeons, the orthopedists, the head and neck surgeons, the obstetricians, the gynecologists, the plastic surgeons have all signed on a letter in support of continued supervision by a physician of CRNAs. They are well trained, they are wonderful people, they are friends. However, they should not practice independently, and they should always be under supervision of a physician. Thank you, Madam Chairperson.
Thank you, Dr. Snyder. Are there any questions for Dr. Snyder from anyone on the panel? Thank you so much for participating and being so patiently waiting. Next, I think we have Dr. Katie Bridges.
Healthier South Carolina. And my thoughts on this are very clear.
Dr. Bridges, are you there? Okay, bring her back. Dr. Bridges, if you can log back on, we will come back to you in a few moments. Technology is working at our best. That's me. There she is. Dr. Bridges, can you hear us?
I can. Can you hear me?
We can. We are glad you are there. You've got about 2 minutes if you'd like to explain to the committee why you are here.
Thank you so much. So my name is Dr. Katie Bridges. I am an academic anesthesiologist. I work at MUSC in Charleston. Been in practice for about 8 years now. I wanted to speak on 2 issues specifically. One about the rural access to care. So a few years ago, the University of South Carolina actually sent out a survey to the various hospitals in South Carolina and asked them why they had trouble recruiting surgeons to work in those areas. And the requirement to supervise a nurse anesthetist was not named by any hospital as a potential issue for recruiting surgeons. It was the things that you would expect. So quality of schools, extracurricular activities, neighborhoods, things of that nature. So I think to suggest that surgeons are more likely to work in a rural area because they don't have to supervise nurse anesthetists is factually incorrect. Secondly, I wanted to speak to South Carolina compared to the rest of the states in the United States. There's a lot of talk about how other states allow independent practice. And I think it's important to note that there are only 5 states in the United States currently that allow independent practice of nurse anesthetists. Therefore, South Carolina would be considered an outlier in allowing this law to pass. Georgia does not allow independent practice. South Carolina currently doesn't, and North Carolina, our neighbor, doesn't as well. I think it would be a step in the wrong direction for our state as far as patient safety is concerned. And I can say that, where I work, we take care of the sickest of the sick. I've seen how badly things can go, how quickly they can go downhill. And I think having a physician at the head of the team is the correct thing for the patients of our state. given how, in general, unhealthy some of our patients actually are. And if it were me or my family having surgery, I would absolutely want to make sure that there was a physician in charge of the anesthesia care. I think it's what our patients deserve.
Thank you, Dr. Bridges. Are there questions for Dr. Bridges, Representative Hill?
Thank you, Dr. Bridges. In your professional experience, can you tell us whether there would ever be occasion to have an anesthesia as its own procedure, not connected with a larger surgical procedure?
Never. In order to have anesthesia, something is happening to your body surgically.
And Dr. Bridges, I appreciate your confirming that for me. That's what I thought was the case. So can you tell us now whether there would ever be a situation where a CRNA would be performing a surgical procedure?
Not that I'm aware of.
So if there's no surgical procedures being done by a CRNA, and they would never be practicing except for in connection with a surgical procedure, which would be led by a doctor, wouldn't it be true that regardless of this bill, that a physician will still always be in charge of the team that's performing all of the care connected with that procedure?
A physician will be in the room while care is administered, but that doesn't mean that they're in charge of the team. And this goes to also ensuring a patient is appropriate for surgery. I think a physician is uniquely qualified to make sure a patient is healthy enough to survive surgery and an anesthetic. And I think that that is not training that is provided in nursing school.
Okay, thank you.
Well, thank you, Dr. Bridges. It appears that there are no additional questions for you. I think we have Dr. Ebony Hilton on the line.
I think a physician is uniquely qualified to make sure a patient is healthy enough to survive surgery and an anesthetic.
Dr. Hilton, can you unmute?
Yes, hi.
Yes,
okay, thank you.
We caught up, yeah. Well, thank you, Dr. Bridges. It appears that there are no additional questions for you. I think we have Dr. Ebony Hilton on the line. Dr. Hilton, can you mute your online streaming?
Yes, can you hear me?
Yes, we can now.
Hi, it's very good to see you. My name is Ebony Hilton. I'm originally from Little Africa, South Carolina, so when we're talking about rural America, we literally are talking about my family. But I did all my training at MUSC in Charleston, South Carolina, and I'm currently practicing at the University of Virginia. And the reason why I thought it was imperative for me to talk is literally, like I said, my entire family still lives in South Carolina, and there's this big push that says that this is supposed to improve access to rural America. And I think we have to take into account what we're talking about here. We're talking about people. Oftentimes we put up this front of this is a money issue, and I tell people all the time, we don't treat bills, we treat individuals. We treat sons and daughters and husbands and wives. And what we know is in those rural communities, what we also see is that there's a larger percentage of persons who are Black and brown and or poor. And unfortunately with those, in those areas, we also see a higher level of disparity. We see that people have higher rates of hypertension, higher rates of heart failure, higher rates of renal disease and renal failure needing dialysis. COVID has kind of exacerbated this issue of showing exactly where those pockets of illness are. And so I would question you, if you have sicker people in a region, do you want to take brains out of that room that could care for those people, or do we need to add more brains into the room? There was an example given of a code that was being performed of a person who was having an endoscopy, and the statement was that the physician said, "What do I do?" It was because the camera didn't cause the person's heart to stop. The medications that were given caused the heart to stop, and that's where it comes into having a foresight to say, what am I actually giving to this patient, and what is their underlying health condition before I give them this medicine, so that we can make sure that we're not giving them too much, and also that we can make sure that when we're doing that intervention, can also counteract it. And that's what it comes down to. Like I said, I'm a critical care anesthesiologist, which means I cover 30% of the time in the ICU and 70% of the time in the operating room. And what we have to realize when we're considering this bill is that the operating room is not your physician's office. It's not where you're going to get your regular checkup for your high blood pressure or diabetes. In the operating room, it is like my ICU on steroids, meaning that literally every beat of the heart, something can go wrong. And how do we make sure that we are ready and prepared? And the way that you're ready and prepared to that, it really comes down to your training. Are you recognized, are you at least trained and prepped of how to diagnose diseases before they happen? We're not there to recognize symptoms and treat after the person's heart has stopped. I want to actually make sure your heart doesn't stop in the first place. And that's the difference that comes along with our training through medical school. And that's the difference that comes along with our training during residency. Even after training, when we're working, clearly I probably look tired because we don't have
Hilton, I'm sorry to interrupt you, but I don't know if you heard, but we've got about a 2.5 minute time period, and I'm going to leave time for there to be asked questions if there are members of the committee that have a question for you. Thank you very much for coming and participating and testifying before the committee.
Thank you.
I think our final person to sign up to speak is our Dr. Bob Wilson.
Yes.
Dr. Wilson, can you hear us? I know we can hear you.
I can hear you fine.
All right. Well, you have about 2.5 minutes.
All right. Thank you. I appreciate the opportunity to talk. Again, Bob Wilson, I'm a physician anesthesiologist who practices in Salisbury, North Carolina. I am currently the president of the Pain Society of the Carolinas, which encompasses both North and South Carolina physicians. And my South Carolina colleagues told me about this legislation that's pending in South Carolina and asked me to say a few words. The main reason I think I'm talking today is that I have a unique perspective in that I was first trained as a CRNA, went back to medical school later in life. My background in nursing training, nurse anesthesia training, was I got a degree in nursing. I worked 2 years as an intensive care nurse and then went through a 2-year course of nurse anesthesia, graduating with a bachelor's degree in that. I believe now the nurse anesthetists who are trained go through a 3-year course of study and then graduate with a doctorate in nursing practice. I believe that's correct. I had all that training, and then physicians who go through the normal route, who don't go through what I did, will go through 4 years of undergraduate training, 4 years of medical school, and then 4 years of anesthesiology residency and internship. After I completed my CRNA training, it took me an additional 10 years to go back to medical school and complete my training in both anesthesiology and pain management, which I maintain board certification in that. The point I'd like to make today is that I have a distinct knowledge about both disciplines. And what I'd say about it in brief is that my depth and breadth of knowledge about human anatomy, physiology, and then the disease states that we have to treat is much more enhanced now, having a medical degree versus a nursing degree. I thank my nurse anesthesia colleagues that I have worked alongside in the past. I have nothing but respect for their abilities, their knowledge, for the level of knowledge that they have. I was there once myself. But rather than go through the processes of trying to legislate myself into the practice of medicine, I chose to go back to medical school and spend the time and effort to do that and practice medicine here today in North Carolina.
Thank you, Dr. Wilson. Are there questions for Dr. Wilson from any of the members of the committee? Thank you very much.
Thank you.
Are there questions in general for anyone on the committee? I've got a couple, but I wanted to give you all an opportunity if you had questions for any of those specifically that are here and any of those that are online with us. I don't know who would be the person to answer this. I'm sure I might get different answers from both sides, so I'd like to hear both sides. The question I have is, there was a reference to 42 states that do not have this supervision requirement. And then there was a reference to 5 states that have independent practice CRNAs. So I'm trying to figure out which is it, and I'm also interested in understanding why the guidelines and the training and the adaptation of guidelines isn't being addressed, because it is in fact in the statute, what we're trying to address here. So if someone can clarify to me the difference in this 42 states versus 5 states, that would be very helpful. Ms. Aguilar, Dr. Aguilar.
So 42 states do not have the word supervision or have removed it. The 5 states is completely, I mean, they may have had independent practice above and beyond, but 19 states have taken the federal opt-out for CMS supervision with a letter written by their governor. So 5 is completely, doesn't account for those states that have done that. The CMS opt-out of physician supervision for reimbursement under Medicare Part A. So that's 19 altogether. Now, in the other states that do not have the word supervision, they may have another word like collaboration or direction or coordination that defines the relationship, but it is not supervision. And I do have a dashboard here that tells you exactly what word is used. And if you don't have one, I'd be happy to give this to you.
If you could provide it to staff so that could be shared with all the members on the committee. Dr. James?
Yes, ma'am.
All right.
So
You're
when you talk
responding to
about-
the same question?
Yes.
Thank you.
Wordsmanship doesn't change the intent of the law. What 45 states out of 50 have is effective requirements for physician involvement in the performance of anesthesia by CRNAs. They call it different things. It's not worded exactly like our law is, but it is declared essentially the practice of medicine. And since nurses do not have prescriptive authority in these states, for anything to happen, it has to be done with the direction and or supervision of a physician. And so, call it what you want to. The words used may be a little different, but the effect is the same. I've practiced here, Georgia, and Texas. The statutes don't read the same, but they require the same thing in effect. The physician has to be present for this to be, it has to be responsible for what happens.
Thank you. Are there any other questions? Mr. Hill.
Just want to point out for the committee's benefit on page 3 of the bill, lines 4 and 5 says a CRNA shall practice, and this is what's currently in state law, CRNA shall practice pursuant to approved written guidelines. Further down on the page, on page 3, lines 28 and 29, the original and any amendments to the approved written guidelines must be reviewed at least annually. And it's clear in both of those sections that these practice guidelines that the CRNA is practicing under are developed in conjunction with licensed physicians and medical staff within the facility where they practice. So in the context of a care team, I think that, the case could even be made that, if we want to make points about what words are used, that this bill, even as we're proposing to change it, doesn't put us in the category with 5 states. It puts us in the category with all the other states that have some sort of guidance in place that governs, how the CRNA must work with the physician-led team within those hospital practices. That's still going to be the case under this bill, even without the word supervising, which is being struck throughout this bill. So I would suggest to the committee that, either supervising matters or it doesn't. And I would argue that, if it's good enough for an APRN, which, Chairman Brawley, you and I were both on that committee, as well as several others in the room were on that committee. that addressed those issues at length. If it's good enough for an APRN, it should be good enough for a CRNA. And I just can't for the life of me, and I've looked at this pretty in depth, pretty thoroughly. I've talked with both sides at length, and I can't for the life of me decide why I would, as a state representative, be in any way qualified to tell a CRNA who has been thoroughly trained what he or she can or cannot do. And so I just wanted to put that out there, Madam Chair. I appreciate your giving this bill a hearing.
Thank you, Mr. Hill. Any other comments or questions? Well,
Madam Chairperson, this is in tab 3 of your folder.
we have had fairly extensive testimony today, and I want to thank again all of you who have come to testify, all of you who have called and written and asked for a review of this bill. We know that this has been something that has been under consideration for some number of years. We have a lot of information still yet to digest as it relates to what you all have presented in form of testimony today. I'm not prepared, I'm not certain that we are prepared unless there is some decision by the body here to actually render a vote today. And there have been a request. Ms. Murray, do you have a request with regard to the status on the debate today?
Yes, I have heard from both sides, and I'm undecided, so I'd like to adjourn with a debate.
So the motion has been made to adjourn debate on the bill and give you all a bit more time to review the documentation, the voluminous documentation that we have been provided. And we will, if there's a second, we will move to a vote. It's been seconded by Chairman. Yes, you may.
Just one question. Do you have any guidance for, or can you set the expectations of our committee as to when we'll be taking this up again if we vote to adjourn debate today?
Excellent question. It's my intention to do so next week. We are looking at what space is available. We are nearing the end of our session, and there are quite a few committees that are meeting. So we are looking at possibly coming back to render a decision on this next week once you've had a chance to review the documentation and you've heard the testimony that you've heard today, and review whatever other documentation that you may have gotten today even in reference to the bill. That is the intention that I have. If that is agreeable to the members of the committee, we have a motion on the floor to adjourn debate. That motion has been properly seconded. We will call the roll.
Ms. Brawley?
Aye.
Mr. Hill?
Aye.
Mr. McCabe? Ms. Murray?
Aye.
Ms. Robinson is absent, and Mr. Howard?
Thank you again for coming. We will be scheduling a meeting on next week. All else works well and we're able to get the space here. We will be rendering a decision on the bill in subcommittee next week. Thank you all for being here.